Hello, I'm Roger McIntyre, Professor of Psychiatry and Pharmacology, University of Toronto, and Head of the Mood Disorders Psychopharmacology Unit, University Health Network in Toronto. Welcome to this program titled New Therapies for Major Depressive Disorder, What Every Psychiatrist Needs to Know. Joining me today are two very good friends and colleagues. First, Edward Vieta, Professor, Head of the Department of Psychiatry and Psychology, Hospital Clinic, University of Barcelona, Spain. Welcome, Edward.
Welcome. Thanks, Roger.
As well as Andy Cutler, Clinical Associate Professor of Psychiatry at SUNY Upstate University, Lakewood Ranch, Florida, USA. Welcome, Andy.
Pleasure to be here. Looking forward to it.
Clinicians have tremendous experience with seeing persons who don't respond sufficiently to conventional treatments for depression. And in fact, that is why we're here today, to discuss how we in fact can assist individuals who are not responding sufficiently to conventional first-line approaches. We're going to in fact begin with some new research as it relates to the mechanisms that are hypothesized to subserve this very common situation that is depression, that often persists, often is severe, and often becomes treatment resistant. Secondly, we're going to talk about novel therapies that are available for treatment-resistant depression and how these treatments can help patients that we all encounter in busy office practice. And we're also going to, in fact, share with you a couple of cases that illustrate some of the key teaching points that we want to convey here today. In fact, that segues very nicely to the first case. We've changed the name of this individual for privacy considerations, but this is not a contrived case. This is someone that I saw not that long ago. This is a 32-year-old single white female who has a working diagnosis of major depression, working in the IT sector, that's the technology sector, off work on disability, has a moderate to severe depression as evidenced by the PHQ-9 score of 14 and a fair bit of anxiety as well. GAD-7 score equals 12. A reminder to use measurement-based care in clinical practice. This individual was treated with cognitive behavioral therapy as well as mindfulness-based psychotherapy alone and in combination with inadequate response to SSRIs and SNRIs. Just to complete the case, the thyroid status was normal. This individual was categorically overweight with a BMI of 27.2, smoking cigarettes occasionally, but not misusing alcohol, not using cannabis, some anxiety, but not a focus of clinical concern, and no evidence that this person has bipolar disorder. So first of all, what would you guys do? I'll maybe pass it to Edward first.
Well, thanks, Roger. I think there are many things that we could discuss about this case. I think that we should make sure that we know about the diagnosis, that the diagnosis is correct, make other considerations about the situation of the patient's preference, and to make sure whether this actually qualifies for treatment-resistant depression.
I agree completely, and I think the diagnosis is so critical to make a priority. Make sure bipolar is not a appropriate diagnosis, which was not the case here. Andy, what we're hearing from this case, and this is, as I said, a case I actually did see in clinical practice, has had psychotherapy, has had a couple of trials of antidepressants to minimal avail. How do we define treatment-resistant depression?
This is a very common scenario, unfortunately. Even despite some of our best treatments, we still have people who haven't adequately responded. You know, there's no consensus definition, believe it or not, now for TRD or treatment-resistant depression. Most commonly, what people refer to is a failure of response or remission to 2 or more adequate antidepressant trials. And the problem with adequate is that's not consensus defined either. So what would an adequate dose be? Typically, maybe the highest approved dose if they can tolerate it. What's an adequate duration? 6 weeks, 8 weeks, 12 weeks? But I think most clinicians would say that failing 2 different antidepressants would work. The question also is, do they have to be from 2 different classes? And in this case, there was an SSRI and an SNRI, so that's certainly reasonable.
Andy, what about a patient who had an antidepressant and it was insufficient, and then the clinician added an adjunctive strategy to the index antidepressant? Is that 1 trial or 2 trials?
Yeah, that's probably 1 trial, to be honest, in my opinion. If you haven't had really an adequate trial of the antidepressant before you add something, it's very hard to tell what's going on. And, you know, that's someone that if you see them in consultation, you might consider sort of backing up and starting over again to really verify the diagnosis.
Well, thanks for that, Andy. And I think this is an ongoing discussion. What is treatment-resistant depression? Edward, back to you. A recent international consensus group published a statement on so-called difficult to treat depression. What is that? How's that been operationalized?
Yeah, I was part of this international group that discussed how to make a proposal that was a bit more clinician friendly than the traditional regulatory approaches that are useful to test drugs and for pharma industry, but not so much for clinicians. And we came out with a definition that was more based and focused on functioning and quality of life and closer to the patient perspective. So rather than, you know, strictly defining, and as Andy mentioned, it's very difficult to say what is an adequate trial of an antidepressant, we were more in line of defining difficult to treat depression as a situation where there is no clear acute response or remission, and that the patient is not doing actually well. That's basically the definition, and something new needs to be tried.
Certainly a very common scenario, and I think many clinicians would be nodding their head. This makes up a significant number of people, unfortunately, that they see. In the patient that I had seen who had sequential failure on mechanistically dissimilar antidepressants and SSRI, SNRI, as well as adjunctive CBT, at that point in the algorithm, as I saw the patient, what was immediately entering into my mind was, let's not forget the basics. Is the person, in fact, taking the treatment? Has there been fidelity to the CBT? Does the person have daily structure to their life? In other words, is there structural and behavioral activation? Are they doing things? Also, what about the possibility of exercise? I started to think about. I also started to think about perhaps also maybe alternative pharmacotherapies. And going back to a question I posed to Andy, would it be an adjunctive treatment? Should I try maybe one of the novel treatments for treatment-resistant depression? And I'm not being exhaustive, but these were some of the so-called drop-down menu considerations I had when I saw this person in my office. Andy, back to yourself. Let's just go through that. Can you walk us through what would be some of the evidence-based treatment options for treatment-resistant depression?
Sure. There is a little bit of a long list, and it is growing now, which is exciting to have more options. But typically we talk about adding to an antidepressant. We would call that adjunctive. And we divide adjunctive treatments added to the antidepressant into two categories. Combination treatment is two or more antidepressants together. And the most common ones that we add to our antidepressant might be bupropion, mirtazapine, or a tricyclic antidepressant. Certainly that's what's commonly done overseas. Then the second option would be augmentation. This is an antidepressant plus a medication that's not an antidepressant. And very commonly what that might include would be an atypical antipsychotic, lithium, thyroid hormone, a stimulant, buspirone, dopamine agonists are also tried. More recently, we have glutamatergic options, and that includes intravenous ketamine or intranasal S-ketamine. There are various supplements that actually do have some good data, particularly L-methylfolate. There's also S-adenosylmethionine, SAMe. There are some immune treatments that are getting some play. There's some data on infliximab, which is a tumor necrosis factor alpha inhibitor, even some non-steroidal anti-inflammatories. We know that certainly at least a certain percentage of depression is probably underlying that as an immune or inflammatory mechanism, immune dysregulation. Psychotherapy, as we've mentioned, particularly CBT and interpersonal therapies. There are various brain stimulation modalities now that include ECT, transcranial magnetic stimulation, deep brain stimulation, and even vagal nerve stimulation. And then as you mentioned, Roger, there's actually good evidence for adding aerobic exercise to the regimen.
Certainly an exhaustive list, different levels of evidence for one treatment modality over another. Edward, in the case that we discussed very briefly, any particular approach that is really jumping out at, for you, this is perhaps more appropriate?
Well, I think there are, in this particular case, which as you said is very common, there are several options. One option that one would consider is combination, right? And combination, we know from a recent meta-analysis that it provides you an odds ratio of 1.5 as compared to the usual treatment. So a combination increases, not in an extremely significant, but in a significant way, your chances to get a response, and even more, a little more for remission. The treatments that have been tested, as you said, combination is adding another antidepressant to the previous antidepressant. The most successful strategies involve mirtazapine, some tricyclics, bupropion, but most studies are very small and there are methodologic issues. So I would say that data is supportive, but not totally compelling. And we need more studies and better trials.
I like the fact, Edward, you highlighted the rigor of bupropion. That is the relative lack of rigor with respect to most studies being open label. Bupropion adjunct to other antidepressants is quite common in some parts of the world, but certainly the evidence would not be considered, replicated level 1 randomized placebo-controlled trials. It's a really nice point. Andy, back to yourself. Other augmentation, for example, atypical antipsychotics. What's your thoughts on that?
Well, to your point, Roger, actually bupropion is probably the most common thing that's added in the United States. And again, I totally agree with you about the database not being overwhelming. So I think that most clinicians would consider an atypical antipsychotic at this point. This patient has clearly failed 2 different categories of antidepressant medication. And so I might be a little reluctant to add yet another different antidepressant to the mix. In certainly the atypical antipsychotics, many of them have databases and evidence that they do work. We can see that the list is fairly long. The most common ones that are used, I would say, that have probably the strongest data are aripiprazole and quetiapine, although there are others, as I mentioned, that have data. And if we look at a meta-analysis of augmentation with atypical antipsychotics, you'll see that the data is really quite strong, and particularly for aripiprazole, again, and quetiapine, which have numbers needed to treat of 9, which is quite good when you have a single-digit NNT. Risperidone also had an NNT of 9. There's a combination of olanzapine, fluoxetine. The NNT wasn't quite as good. It was 19. But overall, the odds ratio of adding an atypical antipsychotic is about 1.8, which is really pretty good. Now, of course, atypical antipsychotics do have risks associated with them, so it's important to have true informed consent when you're considering adding an atypical antipsychotic. We know what the common side effects are, but I think a particularly ominous one to consider is tardive dyskinesia. That needs to be discussed. Another one that does have fairly good data is lithium augmentation. It's something historically we've done for a long time. And in this case, the odds ratio is actually about 2.9, close to 3. So very good. There are, of course, practical considerations with adding lithium. Edward, what do you think about lithium augmentation?
Yeah, I think this is a very good strategy, but it's only appropriate for a minority of patients. We have very good experience with it. We traditionally have a bipolar and depressive unit that is very skilled on the use of lithium. I think in general, many clinicians are sometimes scared of using or a bit reluctant to use lithium, but I think it's a very good option. So for patients who are adherent to medication, for patients who are, very strict about taking the pills and very compliant, I think it's a very reasonable option in this situation.
I would have to agree with that. And one of the points about lithium augmentation in major depression is that the doses that we choose may not need to be as high as we typically think about in bipolar. In fact, the evidence seems to suggest that levels in the range of 0.3 to 0.5 might be sufficient for many adults with depression. That has implications perhaps for better tolerability when using that particular option. And Andy, back to yourself, neurostimulation broadly, walk us through what the evidence is telling us.
Well, all of these modalities have some degree of documented efficacy for TRD, but it really does vary. ECT, of course, is the best studied and we know has very high efficacy. And I think we would all agree that that's also a reasonable option, although we tend not to use it early in our algorithm. More recently, transcranial magnetic stimulation does have some evidence with risk reduction of greater than 3 for response. Vagal nerve stimulation, less well studied, and there's some more mixed results here. Deep brain stimulation has a response rate in one study of 64%, but that is quite an invasive modality and not something that's commonly used. So again, there's some evidence for all of them.
That's great. Thanks, Andy. Just going back to the case that I presented very quickly to all of you, in the case, what I recommended to her referring physician was indeed reconsider some of the lifestyle approaches that I mentioned earlier, and also reconsider perhaps cognitive therapy or mindfulness therapy. I really pressed the point around aerobic exercise with her, in part because it was something that she was interested in, but also the evidence-based, either the original studies or the meta-analysis of a whole host of studies provides a fairly compelling story of efficacy of exercise when combined with medication and or with psychotherapy, not just in depression broadly, but also in treatment-resistant depression. And it's something perhaps we don't emphasize as strongly as we should. I also, after a careful discussion with the patient, decided to recommend one of the novel treatments for her. She was especially interested in receiving ketamine, which we give at my center intravenously, and we had that discussion with her and her care provider. What I can do now, if I can, is maybe, Andy, go to yourself. I think you have a case of Stephen you wanted to share with us.
I do have a gentleman that I'll call Stevens, not his real name. This gentleman was very interesting. He was a 42-year-old psychologist, so of course he's very insightful and knows a lot theoretically about depression. And the reason he came to see me was his girlfriend was very concerned. She was getting concerned because of changes in his behavior. He had had a history of several episodes of depression. He described it like he'll fight through it and he'll go through the motions at home and at work, but he described feeling no joy. So of course he had anhedonia. He also had significant fatigue, hypersomnia in the day, feeling hopeless, passive suicidal thoughts. He would drag himself to work. He was able to work, but it really took all of his energy to do that. He started becoming more socially withdrawn, less communicative with his girlfriend, less interested in hobbies. He had a couple of interesting hobbies. He liked to build kayaks, which are like canoes, and he liked to play guitar, and he'd stopped doing those things. And that actually started worrying him as well. He'd learned that that was a sign that something was wrong. In the past, he had failed SSRIs, SNRIs, atypical antipsychotic augmentation had been tried. He even had a bout with transcranial magnetic stimulation. The current episode, when he came to see me, he had already failed mirtazapine, which is a reasonable choice, and was taking sertraline 150 milligrams a day because he'd had maybe a little partial response years ago to that, and he tolerated it. When I first saw him, he had a depressed affect. He forced a smile, some speech latency, no psychotic or manic symptoms. His MADRS score, Montgomery-Åsberg Depression Rating Scale, was quite high at 34. He had a treatment goal to feel more like himself again, to enjoy spending time with his girlfriend, who he loved dearly, and engaging in hobbies and be more productive at work. He apparently was quite good at his job.
Thanks for that, Andy. Certainly not an uncommon situation, and certainly an often vocalized therapeutic objective that many patients have, to feel themselves again. Edward, what would you do in this case?
Well, I think this is, again, a case that we see on a quite frequent basis. This patient has failed on several treatments. Maybe one thing that I would try is obviously psychotherapy, but in my opinion, in these cases, psychotherapy has to be adjunctive to something else in these patients who fail on several treatments. And then I think one of the best options would be to try one of these newer glutamatergic agents, namely esketamine, which can be added to an antidepressant to make the patient improve from the biological and psychological perspective with this combination with psychotherapy as well. So these are, as you know, this treatment, esketamine, is based on a glutamatergic mechanism of action. It's an antagonist of the NMDA receptor, which is a receptor for glutamate, one of the receptors for glutamate, and it's the enantiomer of racemic ketamine. So it's the S enantiomer, which is actually the one that has the greater affinity for the receptor. And the good thing about this, as compared to what you mentioned, Roger, about the possibility to try intravenous ketamine, is that ketamine can be given intranasally, and this is quite much more friendly than the intravenous treatment. And as you know, this mechanism is quite novel because it really carries a total different pathway, which doesn't have to do with the membrane receptors for indolamines, catecholamines, but actually acting on these glutamate receptors. And this carries a potential for a much more rapid onset of action. So that's basically, my thinking about this case. The science behind this product, in this case, esketamine, is a number of trials that have been conducted. One of which I would like to show. There are two that marginally failed to beat the comparator. The one that is the most compelling one is the one that compared esketamine with placebo, both treatments given on top of a new antidepressant. So we have to bear in mind that this treatment was tested against an active comparator. It's not the same when one looks at the effect size or the potency of the treatment, that if you compare against a traditional trial with a placebo alone arm, that in this case, it is much more difficult to beat the comparator. And it happened in this particular trial. And I think this is a very important improvement in terms of our chances to treat patients like this one.
I think it's a really nice point you make. Usually we don't spend too much time on the methodology of different studies, but the point you raised, Edward, is really critical. And that is the design of the esketamine was really one wherein not only was it adjunctively administered, but it was with a newly initiated antidepressant, rather than an antidepressant a patient had been taking for weeks and months. That makes it very difficult to compare apples for apples, so to speak. That is to compare the efficacy of esketamine to other approaches like atypical antipsychotics, because often in those studies, the atypical is added to an antidepressant that had already been around for a while to begin with. So that's an important methodological point. I think what many would be asking, something I hear all the time, Edward, and that is, okay, it shows a robust effect, it's rapid. How long does the effect last? What does the data tell us?
Yeah, this is the great question we always get about it. And I think this explains, this question about why to compare to a new antidepressant, because in fact, we want to have the best of the two worlds, the best of a new antidepressant in terms of maintenance of effect as well. And I think this was actually tested in a very nice clinical trial published by Daly and co-workers, in which we could see that the results of the trial showed that the combination of esketamine and a new antidepressant was much more effective than a new antidepressant alone. So this gives us a new paradigm in terms of not only treating acutely treatment-resistant depression, but actually reducing the risk of relapse by 50%, which is very, very relevant when comparing to what we would do in another case that would be to try a new antidepressant.
Long-term side effects. I mean, as you know, Edward, we've had ketamine since the early 1960s, first approved in the US in 1970 in the context of anesthesia. So there's been a 50-year exposure to this medication in the medical circle, but this is low dose, so-called sub-anesthetic dosing. What does that mean in terms of side effects? What type of side effects do we see with this treatment during the maintenance study?
Yeah, what we see, Roger, is basically side effects that we are used to deal with, like sedation. And as you said, because the dose is very low, it's not a very strong sedation. And we see sometimes dizziness, sometimes dysgeusia, which means an altered sense of taste. We can also feel some headache, but basically the most, perhaps the newest side effect that we are not so used to deal with is the one that derives from the psychedelic effects of this compound. And this is dissociation. It may happen in around 1/4 of the patients that we treat. And it means that some patients have some sense of derealization or depersonalization or some altered perceptions that this is one of the reasons why we always prescribe this treatment in the context of professional healthcare monitoring.
Very good. I'm just looking at this sort of characterization that you described of the side effects, and our own experience has been is that we don't see with ketamine and related formulations sexual dysfunction, something we're familiar with many antidepressants. We don't see the emotional blunting that we see with some antidepressants, and we also don't see the cognitive impairment. In fact, there's a story unfolding that for some people, ketamine and esketamine may actually have some benefits on measures of anhedonia as well as cognitive function. We look forward to more evidence on that, but doesn't seem to interfere with those key dimensions, those key systems. With respect to this case that has been presented, and thank you, Andy, again for the case, I think it comes down to a discussion with patients and patient preference. We rely a lot on educating our patients so they're making informed decisions. And based on what Andy had reviewed around some of the neurostimulation opportunities, that's certainly something one would consider in discussion with the patient. But certainly, in fact, in this particular case, S-ketamine would certainly, in fact, be a consideration as well. Andy, going back to yourself, in Stephen's case, what was actually done?
Well, I completely agree that he would be an ECT candidate, and maybe before we had S-ketamine available, that might have been what I would have recommended, but it turned out that I entered him into an intranasal S-ketamine study. I was an investigative site for the trials, and he got his first treatment and a very unusual kind of response. Within 15 minutes of his first treatment, he reported a sense of calm, and he actually smiled. And so talk about, rather rapid onset. This was within 15 minutes. He had some transient tolerable sedation. He sort of nodded off a little bit, woke back up. And he did have some dissociative type symptoms with some perceptual and time disturbances. Not terribly disturbing to him. It was sort of a curiosity for him. He also had anterograde amnesia for several hours after treatment. As a matter of fact, the next day when I saw him back to do his 24-hour rating scale, he really didn't remember talking to me the day before after the treatment. We monitored his blood pressure, and his blood pressure remained stable. At the 24-hour mark, when I did the formal MADRS rating scale, quite dramatic reduction. His MADRS dropped from a 34 down to a 4, which is indicative of a full remission of his depression, again, within 24 hours. He already described having a better relationship with his girlfriend the morning before he came into the clinic. They actually shared a joke, which he was very impressed with. And he had started going back to wanting to work on his kayak and playing guitar within the first week. So not only rapid reduction of symptoms, but some improvement in functional outcomes and quality of life as well.
Well, that's what's so critical about that outcome you mentioned, Andy. Not only was the depression mitigated, but the patient sounds like they were experiencing more wellness and more engagement in his life. We always need to be concerned about side effects and safety concerns, and certainly we are, and Edward made mention of some of that. Don't forget that ketamine and S-ketamine could be associated with sedation or dissociation, and notwithstanding some of the hopeful data that there may be some pro-cognitive effects in some people. We're always sensitive to the possibility of anterograde amnesia, and certainly any kind of vasomotor changes, blood pressure or heart rate increases. And this, in fact, is a reminder for safety and monitoring. Very quickly, Edward, what is, in fact, the risk management recommendations from the EMA and dosing for S-ketamine?
Thanks, Roger. Yeah, I think the risk management plan can vary across countries, but in general in Europe, what is requested is that the treatment is generally self-administered by the patient, and we teach the patients how to do it because there are several practical issues that have to be followed in terms of the angle and the way it is prescribed. And then it's very important, we discussed the tolerability, but also the safety. The most important safety concern is to take care of the blood pressure. So it has to be assessed prior and after the administration of esketamine, particularly at 40 minutes, because it's generally when the peak comes and it's the time to actually measure blood pressure. And then, of course, because there's a possibility of sedation, even though generally it is quite mild, and dissociation, the patient has to be monitored, as we mentioned, by a healthcare professional until the patient is clinically stable. And that's one difference. In Europe, we really rely on the healthcare professional to decide the time for the patient to go and to leave the clinic. And finally, the risk of abuse or misuse, which has been a concern. We haven't seen this as a real problem, but it has to be assessed before administration and before deciding to prescribe this treatment.
Oh, that's great. Andy, some differences, it sounds like, when compared to the US with respect to risk management.
Yeah, that's true. In the United States, we're required to follow the patient, to monitor them for at least 2 hours after the administration, whether they're stable or not at that point. And really, the blood pressure tends to peak around 40 minutes after, but sedation and dissociation were noted to sometimes persist a little longer. So we have a little more conservative approach. I'm actually a little envious of the European model.
Yeah, I am as well. And I think that it's certainly safety first, but it certainly sounds as though the European approach has been very prudent and certainly supported by the evidence. As is always the case, time goes by very quickly, and perhaps I can begin just to maybe summarize some of the key points here. I think that it's very, very clear that too many patients are having inadequate outcomes or insufficient outcomes with treatment. And too often, patients end up in a so-called difficult to treat or treatment-resistant depression situation. We firmly believe much of this is avoidable with timely and accurate diagnosis and evidence-based treatments that are selected, guided by treatment guidelines. And these are the guiding principles, of course, with measurement-based care. It's really important to be aware of the fact, and we discussed this with the case Whitney and also Stephen, that to the best of our ability, let's optimize the existing therapies we have, integrate them with psychosocial and behavioral strategies to try and prevent treatment-resistant depression. We've talked about a novel treatment avenue, that being esketamine. Edward was correct in highlighting that it's easier to administer treatment when compared to, for example, intravenous, with efficacy and good short and long-term safety and tolerability. As is always the case, there's more questions than there are answers with respect to the multiple clinical scenarios we find ourselves in. And certainly all of us, as we're going forward, are going to be considering, in the algorithm, where does this new esketamine formulation fit in? It has indication now in Europe and as well in the United States and other countries to follow. And I think as we learn more about the treatment and have more experience, I think we're going to be seeing increasing consideration of the treatment and also optimization of its position in the algorithm as we try to provide the best outcomes for patients who are affected by major depressive disorder. With that, I'd like to thank both Edward and Andy for joining me and for this great discussion. Thank you. And thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.